Okay, so hey, Happy New Year. The year is 2016, January 2nd. Today I'd like to do a follow-up video on a previous video that I did, actually the last video I did, which concerned custom trays from deficient impressions. We all get them, and in that video I showed how I attacked the situation. But what I would like to do today is show you what I got and what the end product was when I got the right kind of things to work on. So we're going to go through this rather quickly. I don't want to hold you up, but I did want you to see that if we work towards a common goal, which is for a better delivery of a product, in this case a removable prosthetic, and we ask and work with our doctors to show them there's a better way, it can give us a better outcome. So as you may recall, that video, custom trays from deficient preliminary impressions, I had this case that came into my office with a new account, and the instructions were to please fabricate an upper healing denture, in other words, an immediate denture. And after receiving an opposing model, that triple tray on the right-hand side and this deficient model, I felt it was in the best interest of my relationship with the account and for their patients that I request something better than this model to work off of. So I basically took a picture of that and along with what they wanted, and talked to them on the phone and discussed the fact that we needed a custom tray done. Because when we work with custom trays, as I said in the other video, custom trays are made from overextended models, not underextended models, because we're trying to refine back what we already know exists to a custom tray, in other words, a custom fit. What we're not working towards is taking something totally deficient and trying to make something, a custom tray, out of that deficiency. In other words, we're not trying to guesstimate. So anyways, the doctor was very open to it, and the staff was very open to it. And I appreciated that very much. I do appreciate that very much. And so I went ahead in the previous video and showed you how I made a custom tray. So with that being said, let's move to the next step, which was, what did I get after I made a custom tray off of this model on the left-hand side? What I got was this. And I gave you a comparison so you can see that that was that model that I received initially, that was to make the custom tray on. Well, actually it was to fabricate off of, and I couldn't even use that. I couldn't use it to fabricate, and I obviously couldn't. I needed a custom tray, and so I had to make it off of here, and I showed you how to do that. I got back the script with a wonderful message of custom impression as per my request, and I appreciate the fact that my account felt secure enough in doing that for me and for their patient. And so what I got in return with my custom tray was a much nicer impression, and I appreciate that again. And so from this, I can work off of this, and I can then go forward, and it helps me to give a better product. Because if I made an immediate off this right model, it wouldn't stay in, patient would be very disgruntled, doctor would be very nerve-wracked and disgruntled. This way we have something great to work off of, and so once I get this, I've got to do what I always do with good impression, well, what I do with all impressions that are given to me, and that is I box it with Wonderfill boxing system, which is the Wonderformer and the Wonderfill material. And basically there is a video on my YouTube channel which discusses and illustrates how to use this system, but that's a 3-minute boxing procedure, so it doesn't take any time at all. And what we do is we get a very nice master model from this, because it's an inverted impression, meaning gravity is working to hold that intimate to the stone that I'm going to pour. The stone that I use to pour is the Cocal. That's a type 3 dental stone. Works great for my usage. It's in a buff color. So here's the comparison. Again, this model on the right was the one that I was being asked to work off of, And once I constructed a custom tray using the technique that I illustrated in my prior video, I got back an impression which produced this type of a master model, which is great. I wish all my models look like that. Unfortunately, they don't. But in this case, because we got a great impression and it's boxed and poured, we get a nice outcome. With this, I can work off of, with this on the left, I can work on and give them my best effort, which will relate to something I believe is going to be better than average. And when I set up my immediates, this case is set up halfway. If you recall, that model prior only had an edentulous area on the patient's right-hand side and only 2 teeth. And so I had to use those 2 teeth to come up with an occlusal scheme along with the existing dentition, which I show how I do that in another video on my YouTube channel here addressing immediate dentures. But I selected my tooth form from the centrals and then the width and so forth from the existing dentition. This area was edentulous, as I said, so we filled 2 teeth in here and then placed our cuspid and then extracted the others off the model and put those in, and it gives me a half of a view of what I'm looking to do. Model came in chipped and broken. The pieces were at the bottom of the box, the ones I could find, and I took into account a very tight situation here. There won't be one here because this tooth is almost at its height here. It'll be low, and when I set this tooth, it will be just a little forward. I'm not going to have it canted mesially so much because we're trying to correct some things too. So with that being said, here's my setup arrangement. On the palatal area, just to show you, I don't wax in the palate. I leave that for a secondary thing that I do, and I'll illustrate that to you here in a minute. But I do wax the flange and put everything into place. You can see how I'm addressing the tooth positions to try to keep it basically about the same. So you can see the borders, nice sulcuses, everything's really good. This is the final wax up. The tooth was an A2. Looks a little dark because I think it's a little underexposed on the picture, but I'm shooting these pictures to illustrate stuff, not as much to get graded on my photographic skill. But you can see it's all set up. We've imitated the arrangement. I've actually taken a little bit of this mesial cant away and kind of flattened out the arrangement a bit. But you notice that I try to mimic the tucked in lateral and follow the rest all the way across. I wax everything to full contour. Nothing is ground in. And as you can tell, I don't believe in scratchy lines and over bulbous contours. I try to follow the tooth emergences, and I feel that that gives me all the natural look that I need. And you'll see in the end here that I do get a very nice result. But as you can see, everything is contour perfect, or as far as contour perfect to the emergences in my mind. And then we go from here. We go to the palate, and then in another video on my YouTube channel explains how I do palatal rugae transfer, which is I copy the rugae off the center of the palate for immediate dentures, because patients who have been wearing dentures for 20 years and don't have anything in their palate except a very smooth area will not be accepting. But for immediates, I place them because it helps the patient, keeps the contour. If I'm imitating this contour in the palate, that tongue is used to playing between two points, the dorsum, or the rear end, the rear side of the tongue, the dorsum, the back side. It actually presses up against here and allows air to flow through the center of the palate. Well, I have to address that area and maintain it. If I was just to put wax across it and it was 4 millimeters thick because I'm lazy, what that does is a very big injustice to the patient, because what we want to do is we want to follow the vaulted contour, and the best way to do that is to replicate that area and place piers underneath that replication to hold it off the tissue in a controlled space. So anyways, teeth are set. You can see kind of corrected those. Okay. Then, of course, because it's an immediate, well, actually, I'm doing a lot of my work in this microwave cured stuff now. But it's nice that I'm doing immediates and treatment provisionals with the GC Nature Krill MC stuff, because from the minute I pack it to the minute it's ready to finish, it's 48 minutes. It's 3 minutes in my microwave oven. I take it out, put it on the counter, and let it cool for about 20 minutes, and then put it in cool water for another 25, and I'm breaking it out and finishing. And it just works great. So for this case, obviously, I used it. This is their flask, the FRP flask. It's a great flask, very robust, very thick sides all the way around. And you can see a bit about my bone trim. It's very conservative. Let me go to another picture and I can show you that. There it is. I don't socket anything. I basically just leave it at the surface of the gingiva, and if I feel like I need to, I'll take some down on the facial surface about a millimeter. But I don't touch the palatal area at all, because I don't feel that palatal bone is going to resorb like the cortical bone on the facial is going to. And besides that, if I have more here, that means there'll be more slop in the denture, which means that it'll accommodate a lot of the swelling that's going to occur with the extractions. And it's going to be relined rather routinely for the first month or so until this patient heals up. But this is a Band-Aid, This isn't the definitive denture in this case. This is a Band-Aid. And so, we make a Band-Aid. We try to make it, put everything where it's supposed to be, teeth included, base thicknesses and everything are addressed. But it's a healing denture. But with that being said, I try to leave as much as this as possible, and I try to be as conservative around the eminences as possible, only because if they crush the cortical bone, and that is going to give us more space, and there will be extraction and absorption from the extractions. And so this is just the way I dress it. And I use one of those fiberglass spun brushes, and I can't recall the name of it right off the top of my head, and I use them every day. But anyways, I use that to kind of just smooth it all off so there is as smooth as possible. But you can see what I got, post dams in place, and so forth. Here's the end result after I cure it with the MC product. This was the light fibered material, and you can see all the contours are in place. My only thinnesses are right here. It'll kind of show up as a little blue area right here. That's a little thin right there. But because I put in all of the eminences to accommodate the emergence, that keeps those areas around the necks of the teeth from having that line where the tooth stops and the model begins. And it's a natural contour, fullness at the cuspids. And you can see how everything fell into place. I actually took this case and also darkened the teeth just a little bit because they wanted actually an A35, and so I used the Optiglaze color from GC to darken them just a little bit, you can see. But I thought it was a pretty good result, and you can notice the height of the borders are exactly, would not have been there with the old impression, and only by requesting a new impression and working with my account to come to a better outcome could I have gotten those kind of border extensions the way I needed them. Palatally, here is the contour, and it has been followed all the way across to accommodate that dorsum tongue space. And you'll notice that I picked up the rugae. I don't hand wax rugae in because this is an art class. This is function class. And since it's function class, I have to make sure that the patient doesn't have something very foreign. Like I said, the real reason for putting the rugae in at the immediate stage is because I want to give them something they're already used to. But with that being said, I also have to keep into account that the tissue that I'm taking an impression off of has little sharp spots and stuff that when it's tissue, it's still soft even though it comes to a point. So I'll go over that area with a soft brush just to take down anything that might be sharp or irritable to the tongue. A good way to check to make sure there's nothing there that would irritate the tongue is I take a piece of cotton and I run it up and back and forth in that area, and actually I flip it over and do the same thing inside of the dentures to make sure there's no nodules or anything that can snag snag the cotton and then cause irritation or cut the patient. Anyways, there's the palatal region. And then here's the inside of the denture, just to show you, kind of thin and uniform borders all the way around. I leave the eminences in. When this is extracted, this will all be filled in with reline material. It'll probably be co-soft or something, tissue conditioning material for the duration until the patient's healed. And then we'll come back and we'll hard reline the denture if they want to go that route, or if they're going for a two-phase construction. This is what I always recommend to my doctors. At the two-phase construction stage, then we can go ahead and make a brand new denture, and this will end up being their spare tire. So products used: Wonderfill and Wonderformer from Dental Creations, the Cocal Type 2 Stone from GC America. I use their putty in the other video to make the tray extensions, GC's Nature Krill, MC, which is their microwave cure. Great stuff. 48 minutes from pack to finish. And GC, the FRP microwave flask. Love that flask. 3 years old on that flask, still like running strong. And the Gebd Tribos M Wax from Schutz, if you're wondering about the wax I was using. So anyways, I thought this would be kind of a cool way to follow up on a video I already did. I hope you got a little bit more information out of this. You got to see where I was going, and might give you a little bit of motivation to realize that when you get a crappy impression in like we do, to work with your accounts, to show them the benefit of what you're offering. You know, make a suggestion for the betterment of the patient and for the betterment of the clinical practitioner's reputation. You know, nobody wants to take a bad impression. We all understand that it's difficult at times to take them, especially if you're under time constraints and so forth, and maybe the patient being more or less more difficult than most. But if we can show them that, hey, look, you know, this is much better than what you had, you can show them then the much better result you can give. With that being said, thanks for your time. Have a great day, and please tune in again. And make sure to tell your dental technician friends to stop on by and subscribe to this channel as well. Your interest in it keeps me fired up to make more. Thanks again.